Hello, everybody. Thanks for joining us. My name is Boris Heifets. I'm an anesthesiologist at Stanford, and I do both clinical and preclinical research looking at the antidepressant effects of ketamine. And I want to thank Ben Palanca for putting this panel together, and Dr. El-Gabalawy for joining us as well. So the next few minutes, I want to tell you about some of our work bridging the divide from mouse to human in understanding how ketamine might work and what its role might be in the perioperative period. So you can take a quick look at my disclosures. I'm going to discuss some off-label investigational use of ketamine, as much as possible refer to peer-reviewed literature, unless otherwise noted. So ketamine is actually part of an emerging class of medicines that media and academics are loosely categorizing as psychedelic therapies. And I've listed here MDMA, psilocybin, and ketamine simply because they have the best clinical evidence behind them. And while we can debate about what's really psychedelic, the fact is that this group of drugs share a couple of remarkable properties. And these are all therapies that involve intense pharmacological and physiological manipulations that can induce profoundly different states of consciousness. So in particular, each of these drugs can induce rapid therapeutic effects. And in each case, the therapeutic effect long outlasts blood levels of the drug. So it is very hard to ignore the unprecedented effect sizes that have been reported with these therapies, and the enthusiasm for new treatments for intractable mental illness has fueled these therapies' rapid progress through the regulatory process. So I'd like to reiterate that many of these results are from small trials, and definitive trials are still underway. And again, this is a strong signal, but it's not the final form that these therapies are likely to take, simply because there's a lot we don't know and a lot of potential risks involved. So for example, abuse potential with drugs like MDMA and ketamine, and we simply don't know which patients might be best suited to which forms of therapy for drugs like psilocybin. So focusing a little bit more on ketamine, among this emerging class of therapeutics, ketamine is the strongest clinical evidence basis. It's been around for over 50 years, and a number of high quality studies over the last 15 years demonstrate ketamine's rapid acting antidepressant effect. Notably, the effect doesn't seem to last very long, about a week on average after single infusion. And you can see here one of the earliest studies that show that antidepressant effect quite nicely. And mainstream excitement has been building for several years now, maybe a little bit over exuberant. And what's important, I think, to point out is there's a segment of the population that is prone to misusing ketamine. And even psychotherapists who work with ketamine note that some patients come for the numbing, less so for the therapy. High dose, heavy use, all that's associated with things like bladder toxicity, neurocognitive deficits. We simply don't know enough about the long-term antidepressant therapy with ketamine to be able to fully evaluate it. And again, if you're unaware of this other side of ketamine, pay a visit to Reddit. This is one of the first things I found on the ketamine subreddit. So I want to reiterate, there is an absolute explosion in the number of clinics specializing in ketamine therapy for depression. Getting the mechanism right and understanding how this drug works and improving on it is particularly pressing for this drug. So here what you can see is our team looked at real world evidence from over 178 clinics in over 40 states, and looking at outcomes of ketamine therapy. And what I want to point out here is that just how durable this effect seems to be out in the real world. This therapy is not going away. People do seem to get benefit from it. And again, the issues I've noted about ketamine, its potential toxicity and its abuse liability, that's motivated the search for more precise therapeutics that can harness these therapeutic effects while minimizing abuse potential. So, as many of you know, one of the dominant ideas about how ketamine works focuses on the NMDA receptor, which is a ubiquitous neurotransmitter receptor for glutamate. And in fact, this theory of ketamine's mechanism has dominated the preclinical literature for the last 10 years. And the story has slowly been built up to explain how antagonism of the NMDA receptor results in a surge of glutamate in prefrontal cortical areas and activation of intracellular signaling pathways like mTOR and BDNF release. So unfortunately, though, preclinical models are only as good as the predictions you can make in a human. So if you walk this forward into human testing, you predict that an NMDA receptor antagonist might be cleaner versions of ketamine that are capable, again, of honing in precisely on that antidepressant mechanism without triggering all of those side effects that we're less interested in. And unfortunately, that's not been the case. So each of these figures is from a trial of various NMDA receptor antagonists and glutamate modulators that have basically failed to reproduce the rapidity or the efficacy of ketamine. So it seems that we don't understand ketamine well enough to repeat the trick, and perhaps we should cast a wider net for the mechanism. And in fact, if you look at the literature of the past 40 years, ketamine is well known to have multiple low affinity interactions that may be just as relevant as its effect at the NMDA receptor. One of those receptors is the opioid receptor. And we did the experiment. This is a double-blind crossover trial. And what you see here is that ketamine-responsive patients in blue were crossed over to a condition where they were pre-treated with 50 milligrams of naltrexone, and that's in red. And we found that naltrexone completely blocked ketamine's antidepressant effect, which led to quite a bit of correspondence and has opened up some new avenues of exploration for understanding how ketamine might work. I'd like to point out this is one of the very few findings that defines ketamine or any antidepressants mechanism in humans. There are not that many demonstrations that a selective pharmacological intervention can block antidepressant effects. So this, if we take this as true, then this is a really good starting point for animal modeling, right? We have a pharmacological, what we hope is a fact in humans, and if we can reproduce this physiology in an animal model, maybe we can learn something about the circuits, the receptors, the brain systems that lead to an antidepressant effect. And that's what we've set out to do recently. So there are a number of ketamine relevant mouse behaviors. Again, these are the mouse lines we're looking at, which I'm not going to go into too much detail about. And we're testing ketamine and a couple opioid receptor antagonists with varying specificity for mu and kappa. And the three behaviors that we focused on are locomotion. So ketamine is known to produce this locomotor stimulating effect in mice. Nociception, we know ketamine's an analgesic. And the forced swim test, which is a very crude measure of antidepressant-like effects, which may or may not actually reflect antidepressant activity. And again, I'm going to glide over a lot of data, but after some extensive behavioral testing, we really focused in on locomotion. The ketamine's stimulant effect seems to be opioid receptor mediated, and we can use that as a behavioral output to model and understand some of the neural events that give rise to that ketamine opioid receptor interaction. This is basically what we found, again, looking just at locomotion induced by ketamine. Naltrexone and saline on their own don't do much. Ketamine enhances the locomotor activity, and naltrexone blocks that effect pretty completely. Kappa opioid receptors don't really do it. It seems like it's mu opioid receptor antagonists that are responsible for that effect. So where do we go from here? Now we have a behavioral model for this, what we've observed clinically. So we don't know where in the brain this is happening. So we cast as wide a net as possible, making as few assumptions as we could. And this is what I'll call basically circuit-based therapeutic discovery, where we're using a comparison between two states, ketamine on its own and ketamine with naltrexone, and looking at the difference between those two states to hone in on brain areas that are mediating the antidepressant effect. Whatever is different between those two should be related to the antidepressant circuitry, or at least the opioid receptor dependent circuitry of ketamine. And again, I'll show you briefly how we do that. And what we're relying on here is immediate early genes, which are closely related to neuronal activity. Every time a neuron fires, it makes a protein called FOS, and we can map that across the brain. So we have a behavioral induction of brain activity with ketamine or ketamine and naltrexone. We clear the brains so that they're optically transparent. We image them with an extremely fancy microscope. And you can see here what some of those raw images look like. We register the brains, we detect the cells, and then we count them across the entire brain. We generate region-based statistics as well as voxel-based statistics to hone in on where in the brain is the hotspot. So what does that map look like? So this is looking specifically at ketamine versus ketamine and naltrexone in a mouse. mapping the differences. And what I'd like to point out is there are a number of hot spots and cold spots that we picked up. One of the most interesting ones was actually in the central amygdala, right around here. This is something that has been implicated before in ketamine's actions. And again, we didn't really have any reason to think of this before, but this is why we did a brain-wide search to look for areas that might be mediating this ketamine opioid receptor interaction. And that's actually what we found. So again, this is just a different view of the same cluster of cells that are mediating this that look different when you give a mouse ketamine versus ketamine and naltrexone. And we tested the idea directly. We infused the mu opioid receptor antagonist directly into the central amygdala, looking again at this locomotor stimulating effect, and we see that we're able to pretty effectively block it. So what taken together, this suggested activity in the central amygdala mediates the ketamine opioid system interaction. I'll point out that this interaction looks a little bit different in mice than it does in humans. And that again teaches us something about how we should be using animal models to model human disease states, which are fairly complex. So given all of this information, what is it, we have some a little bit more mechanistic information, and hopefully this will yield more precise therapies. In the meantime, what do we do with ketamine in the clinic? Ketamine clearly has a lot of efficacy. It also has issues. So maybe there's some specific clinical situations that might be particularly well suited to a rapid acting antidepressant. And it just so happens that we're anesthesiologists. And, we usually only address the risk factors that are right in front of us. So cardiopulmonary things are very easy to identify and treat, whereas psychiatric risk factors are generally, it's historically been very difficult, even if we did identify them, to do anything about a psychiatric risk factor prior to surgery. We know that depression is linked to poor outcomes after surgery, but again, you usually don't have time to start an SSRI and wait 4 to 6 weeks to see if it works before going to surgery. So this might be a situation where a drug like ketamine might be useful. Now, before going forward with a project like this, I think it's useful to understand the scope of how prevalent is depression in the perioperative period. So we actually started a screening program at Stanford Hospital. Last year, there were about 16,000, 17,000 patients that were scheduled for major surgery, which we defined by the length of surgery. And among those, we screened out, we used as our primary screening, anybody with a history of depression on their chart, which was about 10%. And we know pretty sure that that's an undercount, that there are probably many more depressed patients, but they don't typically want it advertised in their EMR. Among those, 20% were currently depressed. They had symptoms of depression. Some patients were directly referred from a pre-op clinic. Among those, 63% were currently depressed, showing that humans, when presented with a depressed person, are much more sensitive than Epic's EMR. So looking at these patients, you can see that there's actually distribution. This is the PHQ-8, which is a measure of depression. And you can see that the severity spans the spectrum of these patients. And you can see in stippled lines here, these are what we would consider high-risk patients. And we identify them as high risk because they have moderate or greater symptomatic depression, no antidepressant treatment, no psychiatric care, and in many cases, no actual diagnosis. So this is what we would think of as a high-risk population that we could intervene on potentially to improve patient outcomes. So that's where we're at right now, is maybe we can help these patients. Showing you here, this is what we're already doing in this perioperative mental health screening program. Once we identify a patient with depression, we refer them out to psychiatrists at Stanford, refer them to trials, refer them to local mental health resources. So what you can see here is that we actually, again, while some patients seek outside care, many accept referrals, only a small proportion actually decline referrals. So we have a pretty high rate of engagement. So this really is an opportunity to create the perioperative period as a point of care for treating mental health and potentially improving outcomes. So again, bringing this back to ketamine, that's just an obvious first pass. We have this very effective, apparently very effective, rapid acting therapeutic. And so that's what we're currently at the tail end of, is testing whether ketamine might be an effective antidepressant when given during general anesthesia. So we've identified, a high-risk population. And again, we're trying to see if addressing the risk factor, first of all, can affect the course of depression, and second, was it associated with better overall outcomes in this population? So I'm going to stop there. This is, I think, 75% of the way towards target recruitment. COVID has been awesome. And I look forward to sharing that data with you as soon as it's available. And I want to thank a lot of people, too many to go through individually, but as I pointed out during in these slides, you saw a lot of different names there. There are a lot of people that have put in a lot of time and effort and their expertise in making this work. So again, thank you for your attention, and I look forward to any questions.
Hello, my name is Ben Palanca. I'm honored to serve as a speaker with Boris and Renee for this symposium on perioperative mental health as part of the IARS annual meeting. I'm an associate professor of anesthesiology and psychiatry at Washington University School of Medicine in St. Louis. I'll be talking about the mental health crisis and focusing mainly on depression in this talk. The COVID pandemic has elicited a mental health crisis of depression and anxiety that crosses borders. Within our own country, the U.S. Surgeon General has issued advisory on youth mental health crisis that has been further exposed by the COVID-19 pandemic. And most recently, our leadership has stated that there will be increased talent and treasure brought to this mental health problem in order to increase the parity compared to physical ailments. It's also worth thinking about what we can do in our own sphere using our own expertise. And I'll think about depression in a perioperative setting. Perioperative depression is associated with higher rates of delirium. The rates of depression after surgery or ICU care can range upwards of 40%. And postoperative depression is associated with poor physical recovery, greater rates of hospital readmissions, and higher rates of mortality. Based on this backdrop, it's worth thinking about how we could take care of a patient and what we can do that we're not doing now. This is my vision of perioperative care, and I'm building off of this maxim put forth by Robert Baden-Powell, the first chief scout of the Scout movement. Leave this world a little better than you found it. I would like to think of it as leave our patients a little better than we found them. We have to think about not only how we can help them survive, but what can we do to help them thrive. To do this, I think we have to think a little bit more about the pharmacologic powers that we have at our disposal. Think a little bit more beyond us being airway experts and more towards a superhero, thinking about Dr. Strange, this Marvel superhero, and how he can control time and reality. In our own way, through the medications that we wield, we can consider ourselves masters of arousal states and think about how we can bring those to bear on this crisis of mental health. The rest of the talk, I'll be talking about rapid-acting antidepressants. And they're really important for us to think about compared to conventional antidepressants, which take weeks to work. These medications or therapies involve induction of an altered sensorium or state of arousal. The onset of clinical effects within hours to days rather than weeks, and persistent effects within neurochemistry circuits and networks. Now, brain state markers during administration and subsequent sleep show potential prognostic markers or targets of modulation. And I hope this will come through in my talk. I have to say that our work builds on decades of research in our own department as well as the Department of Psychiatry at Washington University. So in effect, I'm standing on the shoulders of giants from work that was initiated decades ago on neurosteroids and antidepressants in rodents. We work with Dr. Evers, who is our department chair, as well as Dr. Zrumsky, who's the chair of our psychiatry department, together with the medicinal chemist, Douglas Covey. They laid the groundwork for training of anesthesiology leaders in our specialty, as well as psychiatrists, to study areas such as anesthetic neurotoxicity, as well as the effects of ketamine and nitrous oxide as NMDA antagonists that could potentially address depression and acute stress. Many of the trainees end up collaborating with those in my own department and lay the groundwork for me for future studies on ketamine, ECT, and now propofol. And I've had the opportunity as well to work with other investigators on nitrous oxide for depression. And then now we have groundwork for other junior faculty investigators to launch their own investigations on depression in the perioperative setting. Now, as recent as this week, I've been using nitrous oxide to treat depression and suicidality in clinical investigations. Here's a picture of a patient administered 50% nitrous oxide through this setup that was leveraged by Dr. Conway and Dr. Nagley in their pilot investigation of nitrous oxide for treatment-resistant depression. In this proof of concept trial, they noted a significant effect of nitrous oxide on this HDRS depression rating score at 24 hours. This has been followed up more recently with a publication last year as a phase 2 trial looking at different doses of nitrous oxide. That is 25% nitrous oxide as efficacious as 50% nitrous oxide. And is there a difference in side effects? What we found was that nitrous oxide at 25% showed a significant reduction in the Hamilton Depression Rating Scale severity of depression at 2 weeks compared to placebo, but there was no significant difference compared to 25 and 50%. Now for the 25%, there was actually fewer side effects. Now, these are very interesting studies, and I am really I'm looking for other investigators to work with us on addressing important questions regarding this technique. These questions include reproducibility and persistence. We need larger scale investigations to really assess how well nitrous oxide works. And I'm happy to see that other investigators around the world are also utilizing nitrous oxide, not just for depression, but for PTSD. We still don't know, however, about underlying mechanisms at the molecular, circuit, and network level, the when, the where, the how. There is some thought that nitrous oxide might it might exert its effects through modulation of small molecules like nitric oxide in particular brain regions such as the medial prefrontal cortex. Others are speculating that some of the same molecular mechanisms that underlie the effects of ketamine might also be involved in the therapeutic effect of nitrous oxide for depression. Let's look at some of those mechanisms. So this particular group highlights the effect of nitrous oxide on the AMPA receptors and the postsynaptic membranes of neurons in different regions, as I said, in the prefrontal cortex perhaps. And through the administration of nitrous oxide, we have a waking type of EEG and upregulation of MAP kinase with transcription of factors such as BDNF. But many of these factors won't actually be efficacious in their downstream effects until after the nitrous oxide is stopped. And instead, you see slow EEG waves. And so these investigators are hypothesizing that the effects of nitrous oxide aren't necessarily right at the administration of the medication, but actually later on in different states of arousal. We might think about similar sort of approaches with ketamine, where ketamine induces NMDA antagonism at the presynaptic membranes, but also through metabolites affects AMPA receptors at downstream postsynaptic potentials, leading to upregulation of different kinases and expression of factors such as BDNF. So there may be both shared and distinct mechanisms, but it's worth thinking about that many of these actions might occur at different areas in the brain, including cortical and subcortical structures. I've had the opportunity to work with ketamine and investigators in the psychiatry department who were leveraging a 96-hour ketamine infusion, that is 4 days, in patients with depression. And they imaged these patients both before and after this prolonged infusion of ketamine, which was used to investigate whether longer infusions could lead to greater efficacy of treatment, or also a longer persistence of effects. And what we had the opportunity to do was, in working with the trainee Josh Siegel, was to look at these changes in brain connectivity within different regions of the brain. In the limbic system, which is involved in affecting fear and emotion, but also different cortical regions like the default mode network, which is involved in rumination. What Josh found was that when you compared preoperative scan functional connectivity, that is a measure of brain connectivity assayed through the fMRI signals, that there was no difference in the pre-intervention scans, but when you compared pre and post, there was a reduction in the connectivity between regions of the prefrontal cortex and different regions of this default mode network, suggesting that the treatment with ketamine and subsequent antidepressant effects were associated with a loss of hyperconnectivity within those cortical structures. Josh also looked at the limbic system interconnections that is involved in the amygdala and hippocampus, and observed that there was also a reduction in potential hyperconnectivity between these brain regions when they compared pre and post scans. I had mentioned sleep already and potential effects that these antidepressants might work at stages of arousal beyond the actual administration of these drugs. And the same sort of paradigm could extend to ketamine. And the question some of these investigators pose is, do sleep slow waves serve as a potential marker of antidepressant effect or a potential mechanism underlying rapid antidepressants? And this is important because disruptions of sleep have been associated with major depressive disorder since the time of Emil Kraepelin. These particular investigators out of Carlos Zarati's lab at the NIH showed that ketamine administration was associated with an augmentation of a certain measure of sleep slow waves, we call the slow wave activity, when they compared infusions before, that is white, to that they had on the night of infusion, which was in black, and then grays in the subsequent night. And what they found was that this factor of BDNF, as well as this measure of sleep slow waves, was augmented on that night of infusion. What we're showing here are different columns for NREM episode. That is, over the course of sleep, you have different cycles of non-rapid eye movement sleep. And here they're focusing on the first non-REM episode. It turns out that in the depression research, there have been studies of the sleep structure in both the first and second non-REM sleep episode. And this particular marker has been called the delta sleep ratio. Using this marker, the same team look at the possibility that the baseline delta sleep ratio could help predict this change in depression severity, which was monitored here by the MADRS. And what they found was that there was a correlation between the baseline abnormalities in sleep, slow wave sleep, and subsequent response to ketamine as an antidepressant. They looked at their the response to their patients in this study, again, looking at the MADRS, and found that patients who had a greater abnormality in this delta sleep ratio showed a greater response to this ketamine intervention, suggesting that baseline sleep may be an important prognostic factor on whether ketamine could actually work, and that changes in sleep structure after ketamine administration might be an important either mediating factor or marker of antidepressant effect. We've carried over this particular way of thinking towards a study of sleep in the context of another antidepressive treatment called electroconvulsive therapy, where seizures are induced electively under our auspices of anesthetic care, and this has been led by a faculty member in my group named Mehdi Kafashan, as well as our colleagues in the Department of Neurology and Psychiatry. To do this, we use high-density EEG and at-home sleep EEG to investigate whether ECT stimulation can result in changes in brain networks regulating synaptic plasticity. And we can look at the EEG markers that we call CPCs that occur during the seizures. And then we can also look at subsequent changes in sleep structure that we quantify as sleep slow waves and sleep spindles in order to understand more about this reconfiguration in pathologic neural networks and downstream changes in depression severity. For this way, we hope we have a better understanding of sleep EEG as a response marker or mechanistic target. This is important because we think that seizure markers and subsequent changes in the EEG might be important for predicting the response to ECT, which is administered to patients 2 or 3 times a week for several weeks on end. An existing marker for potential efficacy of ECT has also been explored by a group. This is called post-ictal EEG suppression. And it's basically the suppression in brain activity that occurs after generalized seizures. And the question that has been posed is whether this is a marker for ECT efficacy. In order to help other investigators test this more definitively, we've developed certain markers and quantitative approaches to study those markers. And this is through the leadership of a former trainee, Brian Hickman. He was able to work with us and develop and validate a voltage-based automated algorithm for detecting these periods of suppression and then validate against expert read by seizure neurologists. Brian also showed that this marker, post-ictal generalized EEG suppression after ECT-induced seizures, also depended on the type of anesthetic that was used for that ECT. Now, it's important to focus on this particular marker of EEG suppression after seizures because many have hypothesized that anesthetic-induced burst suppression has quiescent periods that might also confer some type of antidepressant effect. So with increasing doses of anesthesia that is GABAergic, you can push these EEG markers from signals resembling non-rapid eye movement sleep to periods of bursting markers and periods of suppression, and this is called burst suppression. Using this approach, Scott Tadler's group out in Utah looked at the possibility that isoflurane-induced burst suppression might have some antidepressant effects. And he had built on some prior studies that were showing some effect. What they did is they used 8 treatments of isoflurane, which encumbered at least 50 minutes of burst suppression. And these 8 treatments were administered over the course of 3 weeks. And for the isoflurane group, there were 8 participants, and there were 20 plus participants in the ECT group. So we compared the changes in antidepressant response for ECT versus isoflurane, and they measured this using the Hamilton Depression Rating Scale. And what they showed in this data was that patients who were treated with isoflurane of high dose sufficient to induce burst suppression showed an improvement in depression severity, persisting all the way out to 4 weeks. This particular approach has been continued at the University of Utah under the leadership of Brian Mickey, and they evaluated propofol as induced burst suppression as a treatment for depression. And what they did was had 10 different sessions over a period of 3 weeks for 10 participants, and they induced burst suppression for a similar duration, about 15 to 20 minutes. They used 3 times a week treatments to resemble that of ECT for the regimen of scheduling. And what they observed is that if they looked at the normalized Hamilton Depression Rating Scale, depression of severity, from baseline up to the mid and end of the series, that many patients showed an improvement in depression. And so these types of studies suggest that it's possible that higher doses of anesthetics, like propofol, that does have NMDA antagonism, among other effects besides GABA agonism, might prove to show some therapeutic effect against depression. We are building on this investigations towards targeting of sleep slow waves using propofol. Our main question is, can we use propofol as a therapeutic probe towards the enhancement of sleep slow waves? What we'd like to do is target this nexus of sleep, depression, and cognitive impairment in geriatric patients afflicted with treatment-resistant depression. So I hope to have some information to show you in the future. In summary, anesthesiologists are in a unique position to reduce the burden of mental illness within and beyond the perioperative arena. As masters of manipulating arousal states, the specialty should provide leadership and fellowships in developing and testing rapid-acting antidepressants. Brain states marked by EEG suppression or sleep slow waves may be critical windows for modulating neuroplasticity in pathologic circuitry and thereby enhance mental health outcomes in our patients. Neuromechanisms underlying rapid-acting antidepressant neuromodulation deserve further investigation. I would like to acknowledge and thank all the sponsors for our work, as well as the members of the Sleepy Brain Lab, which I'm a director of. I've highlighted those individuals who have contributed to this work quite in depth. And I also thank all the collaborators in the different departments of anesthesiology, psychiatry, and neurology at Washington University, as well as my friend and colleague at the University of Chicago and elsewhere who've helped on this type of work. Thank you so much, and I look forward to your questions.
Hello and welcome. My name is Renee El-Gabalawy, and I'm an associate professor at the University of Manitoba. I'm honored to be presenting today as a part of a larger symposium titled Perioperative Mental Health, Molecular Mechanisms to Implementation. Today, I'll be discussing the role of targeted mental health interventions to improve perioperative outcomes. This is my disclosure slide. Surgery itself can represent a highly stressful experience for many and has a unique relationship with psychological factors. However, until recently, psychological factors have not been the focus in the context of surgery. Today, I'll be focusing my talk on how preoperative mental health factors impact surgical outcomes and review some literature on interventions, including some of my own work. The first thing I'll be discussing today is some research on how preoperative mental disorders can impact postoperative outcomes. Overall, this research has been largely mixed. As shown here, summarizing some systematic reviews on the topic, there are variable findings across surgery types and outcomes assessed. For example, when we look at coronary artery bypass, there is compelling evidence to suggest that preoperative depression elevates the risk for all-cause mortality postoperatively. When we look at breast cancer, we see some variability in terms of particular mental disorders and states having differential effects on pain outcomes. There has been considerable interest in the role of mental disorders in arthroplasty surgeries. This likely relates in part to the fact that mental disorders are very prevalent among these types of populations. So they are very prevalent among those with osteoarthritis, for example. Across surgery types, this research demonstrates that mental disorders, particularly anxiety and depression, appear to have an impact on rates of complications, functional outcomes, and chronic pain. Some takeaways in this literature examining preoperative mental disorders impacting on postoperative outcomes includes that first, orthopedic surgeries are the most widely studied. Preoperative mental health condition that is primarily examined is depression, whereas other mental disorders have had quite a bit fewer studies. But there is a significant variability in how mental health is defined. And the results are dependent on the outcome being evaluated. And there's most empirical support on pain and functional recovery. In summary here, although there is good evidence to support the role of mental disorders preoperatively on poor surgical outcomes, more rigorous, well-designed studies are required in this context. In addition to the reviewed body of literature, there's a literature on the effects of state anxiety preoperatively on compromised perioperative outcomes. You may be asking yourself, what's the difference between a mental disorder and state anxiety? State anxiety really refers to the transient mental health reactions, which are highly situational. So for example, someone might experience a lot of anxiety prior to their surgery related to the anesthetic, for example. And this can occur in the absence of a mental disorder. So elevations in state anxiety are certainly the norm when undergoing surgery. However, rates of significantly debilitating state anxiety range in the literature between 19 and 50%. People with mental disorders are at higher risk of having those significant elevations in state anxiety. So you may be asking yourself the so what question. So why is state anxiety important before surgery, especially considering a lot of people or most people experience it? Well, Mavros et al. Conducted a systematic review in 2011 where they examined the impact of psychological factors on adverse outcomes following surgery. This was an interesting study because they actually included those with a pre-existing mental disorder. So they really were focused on those state psychological experiences. And they found that 15 out of 16 of studies included in their report included at least one adverse outcome related to a preoperative psychological factor. Some of the negative outcomes of preoperative state anxiety include increased anesthetic complications, pain, nausea, fatigue, higher rates of delirium, longer lengths of stay, and psychological issues post-op. And it also can confer poor physical functioning, poor quality of life, and more dissatisfaction overall with surgery. In one of our studies, we were interested in elements in the operating room that were associated with elevations in state anxiety. Many elements we specifically asked about, most patients actually did not find anxiety provoking, with the exception of the placement of the oxygen mask, where 1/5 of respondents found this to be particularly anxiety provoking. Interestingly, close to a quarter said that other things contributed to their anxiety in the operating room. And we gave the respondents the opportunity to describe what those things were. And then we analyzed them using qualitative content analysis. The most significant other factor by far was lack of communication in the operating room. So not knowing what's happening next, medical personnel talking amongst each other instead of directly to the patient, etc. The take home here is that taking the time to ensure that you're briefing patients on all steps that will occur in the operating room and ensuring you are talking to them directly may go a long way in terms of reducing state anxiety, which may actually have implications for post-operative health outcomes. Now that we have briefly reviewed both how mental health disorders and state anxiety can impact surgical outcomes, I'll briefly review some of the literature on preoperative psychological interventions. For the sake of time, I'll be only reviewing psychotherapy interventions as opposed to pharmacological interventions. The primary question here is that if we can reduce mental health symptoms preoperatively, what is the impact postoperatively? We know there are a large number of very well-supported treatments for various mental disorders, but unfortunately their impact on post-operative outcomes isn't entirely clear. The evidence suggests that psychological preparation may be beneficial for the outcomes of post-operative pain, behavioral recovery, negative affect, and length of stay. However, the strength of the evidence is insufficient to reach firm conclusions on the role of psychological preparation for surgery. Further analyses and well-designed studies are needed to explore the heterogeneity in the data to identify more specifically when intervention techniques are of benefit and of course for whom. Within the previous review, there was compelling evidence suggesting that relaxation strategies can play an important role in reducing the risk of poor post-operative outcomes, particularly for both acute and chronic pain. This intervention strategy has had the most empirical support, as indicated. Relaxation is a mind-body strategy that often targets sympathetic arousal, and clinically, I use it regularly as a tool for patients to reduce their distress and hyperarousal prior to surgery. Given this, I became interested in the role of mindfulness on surgical outcomes as an empirical question. So mindfulness is the practice of cultivating non-judgmental awareness in day-to-day life. And so mindfulness isn't just about mindfulness meditation, which is can be sort of conceptualized as a relaxation strategy, but really spills over to everyday life. And there is a growing body of evidence supporting mental and physical health benefits of mindfulness, including mindfulness-based stress reduction. Now, this is an 8-week course that was established by John Kabat-Zinn. And there is preliminary evidence demonstrating efficacy in surgical settings. We wanted to understand the potential feasibility and efficacy of preoperative MBSR among total knee arthroplasty patients. I was particularly interested in this population because of the high rate of mental health conditions and state anxiety among arthroplasty patients, as mentioned, and the larger body of literature demonstrating its detrimental effects for post-op outcomes. Patients were randomized into preoperative 8-week MBSR compared to treatment as usual. We utilized the PROMIS measures, which are valid and reliable patient-reported measures to assess a number of clinical constructs. At 6 months and 1 year, we have data on their Oxford Total Knee Score, which is a scale widely used by orthopedic surgeons to assess knee function. And we also had data on patient satisfaction. Now, I recognize this is a very busy slide, but it displays the within subjects analysis showing the scores of the clinical data pre to post intervention and post-operatively at 6 weeks and 6 months. To orient you to this graph, white and lightest blue represent post-operative time points, whereas the 2 other shades of blue represent preoperative data, with PAC being the pre-anesthesia clinic, which typically occurs in Canada 1 week prior to surgery. The comparison was each point to pre-MBSR intervention. It is important to note that although we see significant findings for many clinical constructs, there will be the impact of surgery itself, of course. So despite this, we do see improvements in pain catastrophizing, health-related quality of life, reductions in anxiety, depression, fatigue, pain behavior, psychosocial illness impact, sleep disturbance, and pain interference, along with enhancements in cognitive functioning. Now, as indicated, we did have a small control group in order to examine some preliminary trends of the intervention compared to treatment as usual or control. Here I'm focusing on the outcomes that are most salient to arthroplasty surgeries, pain-related outcomes. As you can see here, although non-significant, we see the intervention group had lower levels of pain catastrophizing, reduced pain behavior, and reduced pain interference after they received the MBSR and prior to surgery at the pre-anesthesia clinic. When we look at 6 weeks post-op, we can see that those trends persisted for pain catastrophizing and pain interference. Again, we were underpowered because this was a feasibility study to detect significant findings, but these trends are important ones. For the Oxford knee scores at 6 months and 1 year, although again non-significant due to these limited cell sizes, the individuals receiving MBSR prior to surgery had better Oxford knee scores at 6 months and 1 year. Not shown here when looking at satisfaction data, we found that patients were also more satisfied with their surgeries at 6 months who received that pre-op MBSR. In order to fully understand the experience of preoperative MBSR and arthroplasty surgeries, we identified a proportion of those who were randomly assigned to the MBSR group to undergo a comprehensive 60-minute interview regarding the impact of MBSR on their perioperative journey. We used thematic analysis informed by constructivist grounded theory to identify emergent themes. So the 3 primary emergent themes were first, the impact of MBSR on surgery experiences, which really represented the core theme. We also recognized an emergent theme was facilitators of change in the context of MBSR and motivations for participation in MBSR. We identified a number of sub-themes within each primary theme, and I'll include an illustrative quote for each. So first, impact of MBSR on surgery experienced. Many participants discussed increased self-efficacy. So this gave me the courage to say, I'm going to get out of this. I'm going to get better. People often talked about improved coping as well with the surgery itself. I would go into mindfulness and say, I will do this and I'll be fine. I will deal with this and I will be fine. So this included during the actual surgery experience, but also coping in terms of post-op recovery. And finally, facilitated relaxation. So I was able to use this training and mindfulness, and my body would relax. Some facilitators of change included openness towards MBSR. So one illustrative quote is, I was very open to trying to get whatever I possibly could out of it. And health-related beliefs. If your emotional health improves, you will certainly improve your spiritual health and your physical health as well. And this is an important component in terms of my treatment with individuals, is that these health-related beliefs do exist and that they do understand the impact of their psychological health on their physical health experiences. And in terms of motivations for participation, there was, of course, the surgery itself. It would probably help me during my pre-surgery, during my hospital stay, and after surgery. It represented a new strategy to try for some individuals. It just made me feel better knowing if there was anything I needed to learn, I was going to try, right? And the commitment. I said I was going to do it, and I felt like because I made a commitment, I should stick to it. So this is an exciting time in perioperative mental health because of the increased recognition of the impact of the mind on the body. When we think about future directions, some exciting avenues include virtual mental health interventions, such as online programming, and apps that can be used preoperatively. My research group is also interested in the use of dynamic technologies to improve mental health. And we are currently conducting a randomized control trial examining the utility of virtual reality mental health intervention to reduce pre-op anxiety. And finally, of course, the broad implementation of personalized pathways for patient-centered care. I'm so fortunate to be the external advisory chair for the Center of Perioperative Mental Health out of Washington University, led by Drs. Michael Avidan and Eric Lenzi. And the aim of this is exactly this. So it's the aim here is to examine the utility and benefit of a preoperative mental health intervention bundle involving both empirically supported psychological treatments and pharmacological optimization. These are my acknowledgements. Thank you so much for tuning in today. I look forward to meeting you all in person in the future, and I would welcome any questions.
Absolutely. Let's let everyone hop in. Thanks everyone for joining. I hope that gave a lot for everyone to think about. I'm going to take first the questions that were already posted on the chat. Let's see here. I think people are still filtering in. Dr. Prelip, you mentioned about battle buddies on the chat about having great relationships with psychiatry, psychology colleagues. Did you have any experiences you wanted to comment there?
Just an affirmatory one. The early months of 2020 were obviously very disruptive to the overall flow of our usual practice, as well as our staffing. And we reached out with our psychiatry colleagues and collectively translated the Army.
Okay. I think he was muted. I think we left off at the Army, Dr. Prelip.
Just to reiterate, this really was a adaptation from the Army Battle Buddy program to the healthcare arena. And we did that with the guidance of our psychiatry department experts. And we aligned senior and junior faculty together, and with a daily connection, which could be as short as a minute or two or as long as required over a cup of coffee. And I think it was universally well received and provided the support needed at that very uncertain time. Thank you.
Great, thank you so much. And I put a link to Dr. Prelip's ANA piece in the chat in case anyone wants to refer to it. Michael Kayatkin at Montefiore Medical Center posted a question for Dr. Heifets, and Dr. Heifets responded to it on the chat. I don't know if Dr. Kayatkin, did you have any follow-up questions on that? Okay. There were a couple questions as well about HCN1 channels, including from Fayang Tian at MGH and Dr. Porosky at University of Wisconsin-Madison that Dr. Heifets responded to on chat. Did either of you have any?
I didn't get a chance to respond to Fang Yun's question regarding HC1. There's some great work coming out on like all of the various mediators. I think we're moving beyond the NMDA, the NMDA theory of everything slowly. And I think that, what we're really missing is a lot of precision pharmacological tools to answer these questions, and also the willpower to, look at other mechanisms in various contexts. So to be determined. There's I just want to point out one other thing, that there's a wealth of real world evidence from clinics across the country that we're collecting, and a lot of analysis from, that's already published that suggests which of these drugs might be interfering with ketamine's antidepressant effects and which ones are probably okay. Lamotrigine, which has some HCN activity, does seem to attenuate some of those antidepressant effects, but again, no RCTs, so anecdata for now.
Great. I had a question from Shizoba Missouri at LSU. I'm sorry, I butchered your name. Did you want to ask your question over phone here, or I can read it? Basically, it was in regards to combination of nitrous oxide and ketamine for depression. Did an effect cumulative, synergistic, otherwise? I am not aware of any ongoing or planned studies on looking at synergy between ketamine and nitrous oxide. I think that's a great, interesting question. I don't know if there'd be a ceiling effect, or whether nitrous oxide could potentially serve as an adjunct for ketamine. So I think that's a great topic for anyone who wants to pursue that lead. You see here. Dr. Juan Piedmont from Chile. This is for me. Burst suppression has been previously linked with postoperative delirium. If I understood correctly, you will try to induce burst suppression in depressed older patients to reduce postoperative depression. Sorry, that's lack of clarity on my side. No, we will be targeting burst suppression to induce EEG slow waves in our depressed population. Dr. Mickey's study was focused on inducing burst suppression using propofol. I think he has an ongoing study as well that is continuing to use that paradigm, and that's burst suppression at 80% burst suppression ratio. Did that address your question?
Yes,
okay.
Thanks.
Great, wonderful. And then Dr. Leonard at University of Wisconsin-Madison, I echo the concern that deep anesthesia may have unintended side effects in elderly patients, such as delirium and POCD. Important to look for the side effects too. Yes, very really good point. Definitely for studies where you're using deep anesthesia, data monitoring the safety board from a clinical standpoint is important. And those are the ones that I saw. And I guess if anyone has additional questions, please go ahead and raise your hand, and I'll call you out so that you can address your question.
I have a question for Renee, actually, and really it's pretty broad, but just what are, one of the challenges that we've had is, in addressing mental health issues is really engagement. And what have you found? What are the most effective ways to get people engaged with any kind of outreach effort? Because that seems to be most of the battle.
Yeah, no, that's a great question. And as I mentioned in qualitative study we did, health-related beliefs were an important component of the engagement piece. So that belief and understanding that psychological health plays a really large role in physical health. And so I think, what I found with patients is educating patients on that, because it isn't necessarily intuitive. Even though the biopsychosocial model of health has been, around for a long time now, I think that a lot of people don't recognize how much psychological health can have an impact on, especially their perioperative trajectory and post-op outcomes. So I think the education piece does go a very long way with these patients in terms of that buy-in, in terms of them getting engaged in some of the interventions that we're proposing. And so, I would say that that's the most important key component of that. And then, I think I also think that if things are implemented in the system, if it's a, requirement or a strong recommendation to engage in a certain intervention, then that will encourage more people to participate as well. So, if it's an elective thing, like, oh, you can do this if you want or not, a lot of people might choose not to because it's just an extra thing on their plate. But I think so the way that people frame these types of interventions, I think, is also important.
We've had a little bit of success by avoiding the use of the term therapy and saying like coaching. So, mood coaching and recovery coaching, when what we're really doing is, CBT like things that we're referring people to. So I think you're dead on though. It's, the way framing is pretty important. I mean, that's sort of what we've found as well, is that the highest risk group are people who don't have anything on their chart, because they're not telling people that they're depressed. They don't have psychiatric care. They have uncontrolled disease, and they're just not engaged with the system. And trying to pull them in, I think, is really that's where most of the benefits are likely to be realized. For trying to justify what we're doing.
Yeah, absolutely. I think that's a great approach. And even as a health psychologist, I find when patients are referred to me, the first thing they say when they come in my office is, I'm not crazy. And, I have to almost educate them on the role of health psychologists, that I actually, all of the patients I do see have, a medical condition or have received surgery. I don't see just mental health patients, with purely mental health. So I educate them on the role of health psychologists and how it is, learning, important principles to be able to implement on their own to lead to greater success in their perioperative journey or, with their medical condition.
What do you think the role? I'm just going to go for it, unless someone else has a question. Somebody else should jump in.
Well, I do have a question for you, Boris, if no one else does. Anyone else have any questions at this point? Well, Boris, do you mind if I ask you a question?
Oh, go for it.
Well, I was intrigued by your naltrexone finding, where you were able to blunt the effects of ketamine. And I guess one question I started thinking about was, are there implications in terms of just thinking about ketamine therapy in humans, in terms of what should they be doing in the context of that treatment? And I started thinking about exercise and the natural release of endorphins, or any sort of adjunct to engaging in the opioid system. Do you have any comments on that?
Lots. I'll try and restrict them. There's been our findings were not generally met with credulity, I guess, which is reasonable. So a lot of people looked at, natural experiment as, well, what if you interfere with the opioid system in other ways, with buprenorphine or with methadone or any other agonists? And I have to say the data out there is not that high quality. So it doesn't seem like, and what we see, or what people see in clinics, in actual, ketamine depression clinics, is that you can still get good therapeutic effects with patients on Suboxone, on opioids. What we did is, it's really a very specific thing, is we gave a very high dose of naltrexone right before, something that saturates, and again, what think there are lots of things we didn't do, like measure was there any kind of effect of naltrexone on its own? There's a lot of literature suggesting that opioids are involved in mood. That on balance, it doesn't seem that naltrexone precipitates depression specifically, but again, that's an important thing that we didn't specifically measure. So I think there's plenty we don't know. It may be more of like a permissive thing that you need an intact endogenous opioid signaling system in order to realize the benefits of ketamine, but I don't think we know that.
Thanks.
Yeah. I have a question for Renee, although again, I want to leave the floor open for anyone else.
Anyone else have questions, or else Boris is going to fire?
All right, I'm going for it.
Go for it.
We're intensely interested in applying, rapid-acting therapeutics like psilocybin, MDMA, et cetera. Some of these have no real role in the perioperative period, to be blunt. But these types, this class of intervention. Ketamine is kind of the low-hanging fruit. It's legal. It doesn't seem to require a lot of therapy. But things where you could pair an adjunct for psychotherapy in this kind of compressed time frame. There are a lot of challenges with that logistically, and I'm wondering if you have, you've been much more involved on the therapy side of things, and what do you think that some of the hurdles might be? These trials are designed with like hours and hours of therapy, before and after the intervention, and that the outcomes look pretty good so far. It's early. Anyway, just wondering if you have any thoughts on that.
Yeah, that's certainly not my area of expertise, but I think it's a really exciting time for that area. But the literature is very new. I actually think that in the U.S., you are all ahead of us in terms of those trials and looking at that preliminary data. There's great stuff that has emerged from the southern U.S. on MDMA, even in the context of combined with psychotherapy for PTSD outcomes. And so I think it's a very exciting area. I think there are a number of barriers, some more obvious than others, in terms of the implementation of these types of trials. Particularly, and there's some unique challenges both in Canada and the US in terms of being able to do the trials in itself. But I do believe that we will be seeing more of those. And I think that I agree with you that I do think that they may have an important role in perioperative medicine, and it will be interesting in the next, number of years to see, the implementation and some early results of those, because I think that they could be highly effective.
It's, again, to me, the question is enhancing engagement, catalyzing. It's not about the drug so much as it is about the intervention, the psychosocial intervention, and catalyzing, the kind of, you don't have the time to do what you need to do sometimes, and kind of getting there a little bit more directly might be helpful. Maybe.
Yeah, no, absolutely.
Wonderful. Everyone, I just got notified this session is going to be ending, and I want to give you some time before the 10:15. Thank you, everyone, for your questions. Thank you, Dr. El-Gabalawy and Dr. Heifets, for joining me on the session. Everyone, for taking time to join us with us today. We'll see you in the other sessions.
Thanks, Ben. Thanks, Renee.
Thanks so much.
Thank you both.
Thanks for coming. Okay, bye.
Bye-bye.